We're going to have our fifth panelist, Julie Mayfield, North Carolina Senator, join us in a few minutes. I'm Barbara Durr. I'm a reporter with Asheville Watchdog, which is a local not-for-profit, nonpartisan organization doing investigative and in-depth reporting. We believe that quality, independent journalism is an essential for healthy and successful democracy. I'd like to provide a little bit of background for those who may not be familiar with our situation in Western North Carolina. In February 2019, the Hospital Corporation of America, HCA, the largest for-profit hospital operator in the country with over 180 hospitals nationwide, acquired Mission, a locally controlled nonprofit hospital system in Western North Carolina. The system bought by HCA is composed of 6 hospitals. The flagship and largest is Mission in Asheville, which is the seat of Buncombe County, and 5 regional hospitals spread across Western North Carolina. Mission was a nonprofit, well-regarded hospital that drew highly qualified physicians to live and practice in beautiful Western North Carolina. Nurses who worked at the hospital at that time say they felt enormous pride and satisfaction in their jobs. That changed with the takeover by HCA, which cut costs to increase profits. Hundreds of physicians and nurses departed. Primary care was axed from the Mission system, and entire medical practices departed. Nurses have since unionized and have regularly protested in the streets about HCA putting profits above patients. They now face dramatically higher nurse-to-patient ratios. Some of the practitioners who have left the region entirely, others joined smaller local hospitals, one by the University of North Carolina, Pardee, and Advent in a nearby city, Hendersonville. Team Health, the private equity-owned medical staffing company, was contracted in 2020 by HCA, now the owner of Mission, to run the emergency department for the system. The quality of care has dropped. Prices have risen. Mission is one of the most profitable hospitals in the entire HCA national network. And HCA currently faces 2 antitrust suits, one brought by 2 cities, Asheville and Brevard, and 2 counties, Buncombe and Madison. The other brought by a series of private individuals and business owners. A whistleblower lawsuit also was just unsealed under the False Claims Act that accuses HCA and Team Health of overbilling Medicare and Medicaid by excessive trauma alerts and conducting an array of medically unnecessary tests. And just a final word on how we got here. The 2019 deal for the purchase of Mission was highly untransparent. The sale was reviewed as required by law by the North Carolina Attorney General and revealed that, and despite a conflict of interest that was revealed by the Attorney General, the board of Mission went ahead and voted in favor of the sale. Every member of that board and every executive at Mission at that time who had any information regarding the sale was obliged to sign a non-disclosure agreement in perpetuity. So each of our panelists today are highly knowledgeable and have had experience with HCA's takeover of the Mission system and its consequences. Our panelist, Mayor Maureen Kopoloff of Brevard, is a retired U.S. Navy captain with 30 years of active service. She served in numerous leadership positions, including commanding officer for over 1,000 personnel and responsible for naval communications from North Dakota to Bahrain. She also served as U.S. European Command Deputy for all of Europe and the Mideast. She retired from the Navy in 2009, returned home to Brevard. She was elected to the Brevard City Council in 2017 and elected mayor in November 21. Brevard, as Mitch mentioned, is actually a party to one of the antitrust suits. Elizabeth Button. Liz Button is co-founder and co-owner of the award-winning restaurant Crudité in Asheville, North Carolina, and its sister restaurant, Bodega La Crudité. She is chair of the Asheville Independent Restaurant Association and the mother of renowned chef Katie Button. And her business is also a party to one of the antitrust suits. Ben Aiken of Lantern Health. Ben is a family physician and an entrepreneur interested in the reemergence of primary care in societal wellness through clinic system level innovation and design. He is founder and president of Lantern Health, a direct primary care practice based in Asheville, where he still practices. He is driven to transform healthcare work for the better of everyone. Before founding his own primary care practice, Ben worked for Mission Hospital in Asheville. Karen Sanders has over 40 years of nursing experience in multiple clinical and leadership positions. She has a BS in nursing from Old Dominion University in Virginia, and MSN in nursing from the University of North Carolina, Chapel Hill. She's a holistic RN nurse, RN patient advocate, and the owner and founder of 2 firms, RN Patient Advocacy and Holistic RN Patient Advocacy Training Institute. She brought holistic stress management for 15 years, taught holistic stress management for 15 years for North Carolina Board of Nursing. Finally, and soon to join our panel, is Senator Julie Mayfield. Julie describes herself as a practical progressive. She is a Democratic member of the North Carolina Senate, representing District 49, covering most of Buncombe County. Julie previously served for 5 years as a member of the Asheville City Council until her election in 2020 to the North Carolina Senate. Her family ties in Western North Carolina go back 150 years. She's a graduate of Davidson College and Emory University Law School and has been an ardent advocate for social justice and the environment. So I'd like to start off the panel with Maureen, who will bring us the experience they have had in Brevard.
Thank you, Barbara. As Barbara mentioned, I'm the mayor of Brevard, North Carolina. Brevard is a small rural town. We have 8,000 residents in the city. We're in the southern Appalachian Mountains. Our entire county has about 32,000 people. We ended up in the last decade or so becoming a retirement destination for a lot of people. And so we now actually have the highest median age of any county in North Carolina. The median age here is 52. However, we also have large persistent pockets of poverty, generational poverty that exist throughout our county, really causing problems where people do not have the resources or options to go other places for healthcare. So we have a small regional hospital. It was founded about 100 years ago by two doctors here in town that said, we need a hospital for our community. Over the next 80 years, our community built that hospital. Individuals and local businesses contributed all the money and built it. And what I want to talk about is what happened when it became part of HCA, part of a large corporate network, and how that has changed and how we as a community have stood up trying to fight back and to really take medicine back at the community level and say, medicine has to support the people in a community. So when HCA took over, we were told, of course, that we would actually have better healthcare because we'd be associated with a big entity. They would have more resources. They would be able to invest more money. They would have economies of scale, so the cost would go down. Well, absolutely everything the opposite happened. Immediately, costs soared. The costs, we were one of the highest cost areas for medical care in all of North Carolina. We also, what happened within the first 18 months is basically every physician under contract that had been with Mission refused to sign the new contract under HCA. And so all of the physicians left, our primary care physicians that were under contract refused to sign, our orthopedic surgeons, our general surgeons, our OBGYN, our urologists, all of these doctors refused to sign the contract because it did really focus on speed, efficiency. It did not focus on patient care or quality of care. And so our community started getting really worried when all of a sudden these doctors that have been here for decades and were really respected and trusted members of the community were no longer under contract with the hospital. We also saw the staffing levels drop drastically. We saw elimination of local services being consolidated into Asheville. We saw emergency room problems, long waiting times, people in a bed in the emergency room for 48 hours before they got transferred for things such as strokes. So really quality of care was going down. We saw aggressive billing, and we saw really a change in how charity care was done, making it much, much harder for those people in need to really get that kind of care. So our community said, we're not going to stand for this. We are not going to just let our healthcare go in this direction. We are going to fight back. The first thing we did was we contacted Sam Hazen, who's the CEO of HCA. And to his credit, he came out here to meet with me. I had a meeting with him about a year ago. And I asked him right off the bat, I said, why don't you just change the contract? Why don't you have a contract where you can actually have doctors associated with the hospital? And I was told, no, it's one contract for the entire corporate HCA network. That it was impossible to do tailored contracts to different areas. We asked about the services, leaving, the staffing levels. And basically what we asked, we said, we want to buy our hospital back. Well, we were told no. As Barbara mentioned, HCA and its little regional hospitals are a big profit center. So we were told no, we could not get it back. We then went to the Independent Monitor, which is a group that is supposed to monitor the agreement that was signed when HCA bought Mission. And it was approved by the Attorney General. And what we found when we asked the Independent Monitor to step in because we felt they were violating the terms of the asset purchase agreement was that there was absolutely no enforceability in that agreement. There are no metrics. There's nothing you can hold them to. One of the things it says is you will have general surgical services available. Well, they cut it back. And I said, well, at what point are they in violation? When there's 3 days a week, when it's 1 day a week, when we're down to 0, but they're trying to hire. And they've always been in compliance, even though we didn't have a general surgeon for 14 months. So we gave up on that. We said, okay, that's not working. So what we next did was the city of Brevard, and I'm proud to say the city of Brevard was the very first entity to file a lawsuit. So our little town of 8,000 people took on HCA in a lawsuit. We filed a class action antitrust lawsuit in federal court, basically alleging that they are engaged in anti-competitive conduct. We are a self-insured entity, which means the city itself does the insurance for our employees. And so what we found was that when we went to do insurance with HCA, that we could not, under our insurance policy, get Mission Hospital as the general acute care center unless we agreed that every single outpatient service was provided by an HCA entity. That's called bundling or tying services together. And it's one of the things that we are alleging is anti-competitive nature of. We also said that they were doing other anti-steering provisions and that they were keeping prices confidential so that you could not compare prices as an insurer to try and figure out where you wanted to get your insurance. So we have filed that lawsuit basically saying that we have higher prices and that we have a lower quality of care, because when you have a monopoly, that in itself pretty well tells you that you don't have to have high quality to get your customers. You're going to have them anyways. And the remedies that we are asking for in that lawsuit is that HCA be directed to stop their predatory monopolistic practices and that they reimburse us for damages. That lawsuit was subsequently joined by the city of Asheville, Buncombe County, and Madison County. It is still in federal court. HCA filed a motion to have it dismissed. We, of course, are fighting that, and that decision is still pending. I am confident we have a very, very strong, nationally known antitrust law firm that is representing us, that it is going to go forward. However, we were not content to just say we were going to take HCA into the legal realm, because we still had the problem of what do you do about the people in this community that need healthcare. And so we formed a community council, a group that was going to go out and is going to document what was happening with healthcare in our community. We held listening sessions across our county. We had several hundred people come to these. We did it for 6 months. We documented all of the problems in a report. We sent that report to Sam Hazen saying, here's what's happening. Some of these things were not just frustrating, but they were really up at the level of troublesome, worrisome, because the quality of care was being so bad that lives were being threatened. It took so long to deal with appendicitis that it ruptures. People were sent home with multiple fractured bones because there was no one to deal with them. Things like that, all documented. Sent it to Sam Hazen, asking him once again to get involved and to try and repair the situation. We got a very dismissive, a very short response back from him. So we now are basically going forward to the state level to regulatory commissions. I'm working on setting up a meeting with the North Carolina Department of Health and Human Services to see where their regulatory authority sort of meshes with what we're seeing as the problems in our hospital. And we're going to continue to move forward both with the lawsuit and with our community efforts to demand that we get good quality care and we have it accessible and we have it affordable. So in the context of this meeting, it's not just all of the doctors fighting back. I think, this has to be really a joint effort where the communities stand up, and communities and the patients and your elected officials, we stand up and we say, we are not going to stand for this. Healthcare is essential. My job as mayor is to make sure that my community is a strong, healthy place where people can live. And I can't do that without effective, affordable, and high quality healthcare. And so as an elected official, I join in this effort of doctors and system, the healthcare system, really needing to be focused on people. One of the interesting things we did find out in our community sessions is that 90% of the people in this community have lost all trust and faith in our local hospital because of HCA. And that's within 3 years of them taking over. I think I'm probably out of time, Barbara. So that's sort of my summary.
Thank you. Thank you very much, Maureen. We're now going to go to Liz Button. Liz, if you want to chime in, please.
Yeah, hi. Thank you, Barbara. And thank you, Maureen, for all that you said. I'm in complete support with you. So just to clarify, I'm a retired restaurateur and currently serve as the chair of the Asheville Independent Restaurant Association. What does that have to do with healthcare? And by extension, why am I talking to you? Well, in restaurants, like many others in the hospitality and service industries, the staff is largely comprised of young people who have not had health insurance since leaving their parents' benefits plan. When I ran the HR department at Curate Restaurants, which I co-founded, I endeavored to educate all of our employees on the importance of healthcare in their lives and provide a health benefits safety net. This was a huge challenge since health insurance is expensive and navigating the healthcare system can be, to say, at the very least, daunting. A major hurdle was finding a health insurance program for our employees that satisfied federal guidelines and was affordable for both our company and our employees. One of the strategies I found very effective was engaging with a healthcare advisor that, first and most importantly, prioritized our company and our employees' needs over that of the profit centers that feed off of our healthcare system. And more specifically, one who was not in some way financially aligned with the big four insurance companies, Blue Cross Blue Shield, United Healthcare, Cigna, and Aetna. An advisor who would prioritize finding a balance between our employees' health and our company's financial well-being. Bear in mind, in this regard, that for most companies in the United States, after payroll expenses, benefit programs represent the largest outlay of expenditures. It was always a struggle to ensure that our staff had good and affordable health coverage while our company remained solvent. Suffice it to say, it wouldn't be beneficial for our employees or our company if the benefits program bankrupt our organization, nor would it company if the health of our employees and their families was not well attended to. Working with the right health advisor, and more on that in a moment, and learning the ins and outs of designing an affordable and top quality health benefits program for our employees opened my eyes to the many financial traps in our current insurance-based healthcare system and introduced me to a different model for providing health benefits that, if widely adopted, could revolutionize and streamline the way we provide healthcare in our nation. Since retiring from the restaurant business, I have decided to devote my professional life to fostering and spreading the word about this new approach, and that's what I'm here to talk to you about today. I was first educated about this new healthcare paradigm by Dr. Ben Aiken at Lantern Health. Thank you, Ben. He directed me to a nonprofit organization, Health Rosetta, where I found a health benefits advisor, Christy Gupton with Custom Benefit Solutions, a certified Health Rosetta advisor, and one of the thousands of Health Rosetta advisors across the United States. Christy helped me create a program of incentives to ensure that our employees had access to primary care physician 24/7 by incorporating 5 direct primary care groups here in Asheville. Some of you, although I think most of you are probably familiar with this, but you might not be truly familiar with the direct primary care concept. We have a lot of them here. We're very fortunate in Buncombe County. One of the pioneers is Dr. Ben Aiken. He will be speaking to you, I'm sure, more about this concept. Direct primary care, or DPC, as it's known in the industry, has the potential to revolutionize how we deliver quality and affordable healthcare to Americans. It has some similarities too, but also important distinctions from concierge medicine. The most important one being that direct primary care operates outside of the traditional US health insurance system, a system, in my opinion, that is in cahoots with hospitals and bleeding us dry, pardon the pun. In addition to engaging with a direct primary care provider, similar savings and efficiencies can be realized in a health benefits program that partners with other providers working on a similar model, a member-based pharmacy where all prescription pricing is transparent and provided at cost plus. Similarly, an employer can enroll their employees in a dental membership plan where, again, pricing is transparent and provided at cost plus. Also important for companies developing benefits programs is to work with so-called third-party administrators who operate in a fully transparent mode and directly negotiates with health providers on costs for care and procedures that fall outside of the purview of the direct primary care provider. These might include visits for imaging, specialists, or surgeries. It's the administrator's job to ensure that the cost for such special doctor's visits and procedures are reasonable and not inflated, and that they are known upfront. No surprises after the fact for the employee or the employer. Think back how many times a few weeks or a month after a doctor's visit or hospital stay that you were shocked by a bill. If you have, you're not alone. And I will refer again to the New York Times article that we all saw this morning. Health insurance has encountered obstacles to coverage, including denied medical care, higher bills, and a dearth of doctors. We can better avoid these pitfalls by working with transparent third-party administrator. So why Health Rosetta? Well, I'm sure there's other organizations that I might not be aware of, but this is one of the nation's leading organizations in advancing this new healthcare paradigm. Health Rosetta is a 501c3 headquartered in Seattle, Washington, whose mission is to accelerate adoption of simple, practical, nonpartisan fixes to our healthcare system. Health Rosetta currently works with public and private providers and unions to provide better healthcare to more than 150 million Americans while reducing costs 20 to 40%. Since leaving the restaurant business, I have embarked on a new project to use the Health Rosetta model to foster a new community-based health provider system in Asheville, a system that would initially allow our small business owners to tap into and provide affordable and top quality healthcare to their employers without breaking their bank or burying them or their employees in endless paperwork and insurance claim forms. I've been using my current tenure as chair of the Asheville Independent Restaurant Association to test and incubate some of these concepts. For example, we have recently initiated a program that allows independent restaurant owners in Buncombe County to enroll their employees at a very modest cost, as low as $1 to $2 per employee per month, for mental health care for themselves, their families, and anyone living in their household. We also provide a membership-based program for dental and direct primary care and discounted pharmacy prescriptions. All of these services, and this is key, are being provided outside of and independent of the traditional health insurance model. Ultimately, these types of programs, I would hope, will eventually be available to everyone in our community. This is just the beginning of what I'm working towards in our community and seeking partners who see the value in a local community-driven healthcare system. If I may turn to the bigger picture, there is a general agreement among the vast majority of Americans, and I'm including politicians on both sides of the aisle, that our healthcare system is broken. Unfortunately, almost all the debate on moving forward has focused on health insurance. The real issue is not providing Americans with health insurance, but high quality and affordable healthcare. We do not need these huge corporate insurance companies to control and dictate how primary care and other basic services are delivered to us in our own community. We can do this better by working together. That's why we're here today. Let's take back medicine.
Thank you very much, Liz. This folds, I think, rather nicely into Ben's presentation. Ben, if you could go for it. I think you're unmuted. Yes, thank you.
Hey, everybody. It's really nice to be here, Barbara. Thanks for hosting, and the rest of the panelists. It's a privilege to be a part of this. So my name is Ben Aiken. I'm a family physician based in Asheville, North Carolina. I think there are two parts of my story that are relevant. One is the direct primary care piece itself, and then the second relates to mission and transitioning mission to HCA. So Liz really kind of set the stage nicely as it relates to direct primary care. I'll spend some time there first in terms of the model, how I came to be attracted to it, and what the benefits are. So very kind of early on in medical school, I realized that I love variety and I wanted to be a primary care physician. I had studied public health before medical school and really was drawn to system level change and really recognized some of the dysfunction in the healthcare system at that stage. And really felt drawn to this concept that basically every high functioning healthcare system in the world is built on a strong foundation of primary care. And yet, majority of conversations that I had had with colleagues or friends at that point really had discouraged primary care. They simply said, great, you're going to medical school. What kind of specialist will you become? You primary care docs work very, very hard and they make hardly any money. So clearly you wouldn't decide to do that. Ultimately, I still felt drawn to do it and saw the dysfunction in primary care at that phase. So I spent as much of my elective time as possible through my training really looking at people trying to do primary care differently. In the current status quo primary care system, the incentive is volume. So the sicker someone is, the more they come to see you, the more you generate. That system is driven by a health insurance reimbursement model. And in essence, what happens, even for doctors that are very well-meaning, is their care, to a degree, is dictated by what the insurance company will pay for. So how they document their visits, the boxes that they check, the different components of what they do is really all geared towards making sure that they get paid by an insurance company. In that payment infrastructure, on average, let's say just for ballpark numbers, you might get paid about 50% of what you bill. And the game is really to never charge less than what an insurance company might pay for. Since there's really no transparency in what anything costs in the status quo healthcare system, no one really kind of knows basically exactly what's happening. So you simply charge a whole lot of money to anyone that has insurance or doesn't have insurance in the hopes that you get paid some percentage of that. That unfairly burdens anyone without insurance in a very striking way, and happens both at the primary care level and at the hospital and specialist level as well. So in my search for alternatives to this, I found direct primary care. My initial exposure to this was in the city of Las Vegas, of all places, where there were forward-thinking people trying to take care of casino workers who historically had been very, very sick and with many challenges on the lifestyle side and needed better options. It was an eye-opening moment for me, and from that point forward, I really sought opportunities to get into a direct primary care model. An opportunity for me emerged early after I had completed training to help the local health system in our community, Mission Health, open and try to do one of these models. The leadership of Mission at the time was drawn to the idea of trying something new because, simply put, they saw the dysfunction that I saw. They were losing money if you took the primary care practices in focus on each of their practices. Their physician satisfaction was terrible, their patient satisfaction was terrible, and they felt like they needed to try something new, and were willing to give me a chance to help them to do that with the direct primary care model. What direct primary care is at its core is just a different financial approach to healthcare. So in a traditional model, I mentioned a fee-for-service model or a volume-driven model. Every time someone would come and see me as a physician, I would create a bill and then file a claim to an insurance company to pay me that bill. So in essence, every time, it's a fee-for-service. So every service I provide, I would send a bill. In direct primary care, you replace that by a monthly fee. So it becomes much like a gym membership where you pay a monthly fee, and for that monthly fee, you get unlimited access to your doctor or your care team, as well as access to various other things. So the incentive is actually flipped. And at the core of direct primary care, I think that's the foundational value, in the sense that my incentive is to keep people as healthy as possible. In my previous model, in previous practice, the sicker someone was, the better I did. So now if somebody in my panel is extremely sick and they come and see me every week, and that happened with all of my patients, the model would break. So the incentive is for me to keep people as healthy as possible. There's also some people would say, well, hey, if that's the case, why don't you just avoid seeing somebody altogether? If they don't come at all, wouldn't that be ideal? The counter incentive there is really that if somebody doesn't like their experience with me because their ability to see me is not tied to their insurance company, they can simply fire me. So the incentive is for me to deliver an excellent experience and really to kind of change the experience of what somebody has from a primary care perspective. Direct primary care overall has been around for probably about 20 years now, in the early 2000s, and really caught fire, I feel like, in the last 5 to 6 years. When we were starting our efforts in 2018, we were, in essence, there was one practice in our community, and now, as Liz mentioned, there are 5 going on 6. We've had really nice growth in a physician-led effort to increase direct primary care. So that, from a DPC perspective, outside of the finances, where things become interesting is, well, what is included in that monthly fee? And for us, what that looks like is we have health coaching available. We have certain lab tests, x-rays, anything that we can't do in-house. We try to have transparent pricing. We really are in a position to help quarterback and care manage and navigate for all of our patients, and really kind of deliver on the promise of what we should be as somebody's primary care provider or physician. It is a wonderful way to practice. Our patient satisfaction has been exceedingly high, higher than I could have ever expected. We measure that through what is called a net promoter score, which some of you may have heard of as kind of a standard across certain startups in terms of how successful they are. Our number has been north of 90 since we began. I don't know that we'll be able to sustain that, but the feedback we get is quite incredible, and we take great pride in that. We take care of individuals and families who simply are looking for a better option for primary care in our community. And increasingly, we take care of businesses. 55% of our patients come from local businesses. We now take care of over 60 local and regional businesses who are looking for better options with more transparency and higher quality and a better experience, as Liz spoke to earlier. And direct primary care fits really nicely in for businesses of all sizes. Our business sizes range from a 3-person watchmaking shop up to a 450 employee retirement community with manufacturing, restaurants, any number of different industries in between. And they are helping to drive the change that we need to see on the health insurance, healthcare side of the equation, as Liz spoke to. So that is, in essence, the kind of the direct primary care piece. I'll speak now to what I referenced earlier, which is kind of the second aspect of my story that I think is relevant here, which is I helped to launch this practice on behalf of our local and regional health system, Mission Health, back in 2018. I was a bit skeptical, I think, of large health systems generally as cruise ships. They are you can turn the wheel for a long, long time and you won't get much motion. But here was a local nonprofit health system that was very connected in our region, who was looking to try to do right by their patients and felt like this was a unique opportunity to pilot, and it was worth. There was trust there, and we launched the practice. Not long after we launched, the sale of the system to HCA, which was previously referenced, was announced. That sale went through a little over a year after we had opened the doors to the practice. And approximately 1 year later from that, I purchased the practice from HCA because they were going to close the practice down. They are not generally interested in primary care if you look at their national footprint, and are generally very open about that. In acquiring our system here in Western North Carolina, they acquired a large footprint of primary care. And as we've seen over the last 3 years, an increasing number of those primary care practices have transitioned out of the system. And ours was simply one of the first to do so. And along with that, I have watched colleagues of all specialties, primary care and otherwise, also increasingly transition out from HCA to other entities, both in the private sector as well as the VA, as well as other hospital systems that are in our region, due to all of the changes that we hear about that are having such a negative impact on patient care within HCA. So now being kind of on the independent side, I am still just as passionate about trying to create change at scale. It is a slightly more challenging road to seek without the support of an entity like an integrated health system. But nonetheless, we have, I think, achieved good growth. I have hired 4 additional physicians. I have hired a 5th. We are planning to open a 2nd location in September of this year. We are part of a rising tide. We are just one entity and relatively small in terms of our footprint, but are very much focused on trying to be a leader in our community and sharing what we've learned with other folks that are trying to do things in their community. You will hear people talk about healthcare being local. Maureen spoke to this earlier. There is a sense of connection that people have as it relates to getting their healthcare, and it is very personal and very intimate at times. We all ultimately are going to get sick and need to have healthy relationships with our physicians and providers. And so having that connection in your community, somebody who can help you navigate, to the resources that you need, I think is critical. And so we are really excited to be a part of a growing movement called Direct Primary Care, which is growing quickly at a national level. It's still in the minority in terms of how people get their primary care, but the value we're creating and the data that is starting to be shown conveying that is increasingly compelling. I will leave it at that for now, Barbara.
Thank you very much, Ben. Very appreciate that perspective. We're now going to turn to Karen Sanders, who I think will be providing us some information about the consequences for patient care under HCA. Karen?
Thank you, Barbara, and thank you, Maureen, and speakers about all of your wonderful work you're doing. So I've been here in Buncombe County for 37 years and worked at Mission Hospital, which was purchased by HCA. I worked there for 16 years. I worked at Transylvania Regional Hospital, which was a wonderful community hospital, for 7 years. Worked at Care Partners and also was a practice administrator at one of our hospitals. All of these places prior to HCA worked collaboratively. We held hands together. We donated our time and our resources back to the community. In fact, the year I left, 2002, that Mission Hospital donated $500,000 to United Way. So fast forward to 7 years ago, I decided I was starting to get concerned about our segmented, silo-driven healthcare system, and that I wanted to go into private practice as an RN patient advocate, helping patients and families navigate our dysfunctional, silo-driven, dismissive healthcare system with less stress and more peace of mind. And as some of our speakers have spoken to, HCA for-profit did buy Mission Hospital in 2019, and that's when I started getting lots and lots of calls for people to help me in multiple places along the healthcare continuum. Just want to say there are some attributes of the U.S. healthcare system that have already been mentioned, and those are that we currently are in the worst RN patient nurse shortage of my career, of my lifetime, and we are expecting to lose about 100,000 nurses next year. We are also in the midst of a huge CNA shortage. Also, and in our community, we don't have enough RNs, we don't have enough CNAs. That's not only for hospitals and health departments and private practices and skill facilities and assisted living, it's for people who are contracting nurses and CNAs to live at home. Another part of our landscape of healthcare is that medical errors are one of the leading causes of death, and 80% of all errors happen at handoff or transitions of care. So when a patient leaves the hospital and goes home, that's an example of a transition of care. Or if they leave the hospital and they have to go to home health, or leave the hospital and go to skill facility, that is a rich environment for errors. Another key thing is that medical literacy is an issue that people don't understand. Our gigantic system of acronyms and words people don't understand, and how does it work? We also have a shortage of primary care physicians in our community, and it's really hard to find a doctor. So there are many factors that go into what's happening with our U.S. Healthcare system. So I'm just going to focus on what it's like for me to be an RN patient advocate. I started this business 7 years ago, and I have been completely inundated with patients and families who are lost in the healthcare system, who feel devalued, dismissed, and don't know where to turn. They feel hopeless. And this is all in the whole setting of having themselves, their family members, or anyone else who is very ill, and they are in an emotional and a physical and a mental and a financial crisis all at the same time. So what happens is people find me by my website, or most of my consults come from people by word of mouth. And I still do a lot of other community work besides my RN patient advocacy work. So I was so inundated with patients that I decided to start a school called the Holistic RN Patient Advocacy Training Institute. So now I train nurses all over the country to become RN patient advocates, just because our healthcare system is so broken. I also teach a course on helping patients become advocates for their own healthcare, and that's offered at no charge. And one of the things that's happened during the last few years, most of my consults have come from patients being hospitalized at Mission Hospital. And so the kinds of complaints I get are, I'm in the hospital and nobody is answering my call bell. These are the complaints that come from Mission Hospital. Hospitals, I'm in the hospital and I'm supposed to be transferred to a rehab facility. And they're telling me I have to go to this rehab facility, which has got a very low 1 to 5 star rating by Medicare. And I don't want to go to a 1-star facility. I want to go to a 5-star rating. Also, I can't get my medical records. I've asked, I've complained, I've called. I cannot get my medical records. And so that's another issue. Getting an insurance bill that's itemized is very difficult. And then finding out, where do I get the cost estimate that the federal government has mandated from a hospital website to find out, for example, how much does a CT of the abdomen cost with contrast? So those are kind of like the 5 most frequently asked questions within the hospital setting. I also wrote a blog last year just for patients to be able to get some help, and that's called Patient Advocacy During a Hospital Stay. So now I'm training nurses all over the country to try and become patient advocates in private practice. I'm independent. I don't rely on any other entity for my own work. And that allows me to be able to speak freely without causing disruption from other healthcare agencies. I would like to just share 1 or 2 stories with you about current patients that are in the hospital. So one patient is a nurse, and he has been hospitalized at Mission Hospital for 14 years. He was out in his driveway, and unfortunately, he slipped and broke his ankle in 3 separate places. It was a really terrible break. He was admitted to the hospital on June 1st. He still remains there. He's in the hospital for 14 days, and he had 2 terrible issues that happened to him while he was there. He was scheduled to, he had external fixators. There are these metal contraptions that stabilize your ankle with all the fractured material. And he was scheduled to have the surgery a couple days later after the external fixators were affixed. And then he went down to the OR to have his surgery. And the OR staff, the physician, the surgeon, learned that when he looked at his wound, where these pins were in, were bleeding. So they did his blood work to show what his coagulation, what his ability to blood clot was, extremely abnormal. So his surgery was canceled. So he went back upstairs, and then they had to stabilize his bleeding times. And then he was scheduled for surgery for 3 days later to have the same surgery. So when he was getting ready to go down to surgery, the nursing staff was notified that, well, your surgery's been canceled because we have a shortage of staff in the OR and we can't do your surgery today. So he now has had his surgery, and now he's trying to get admitted to a rehab facility because this is a very bad break and he needs some extra help with physical therapy and occupational therapy. So in my work, we know that there are OR staffing issues. There are nurse shortages on med-surg units, ICUs, out in outpatient areas and in ER. And so what in the world is an overwhelmed patient supposed to do in these kinds of situations? So in this case, I work with patients and families individually. I sometimes go to the hospital and visit with the patient. I write notes on their grease board. Some of the administrative staff at Mission know who I am. And it's just a difficult road to teach patients how to advocate for themselves. But one of the things that is important to know is to never give up on your healthcare. And I have a favorite quote by Winston Churchill, which says, never, 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 never give in on your healthcare. So my job is to help people get through these episodic crises, help them get entry into their medical records while they're in the hospital. When they call me at 10 o'clock at night and they can't get in touch with a nurse, I ask them to hold on a minute. I'll call the hospital operator, ask them to be connected to the nursing unit on which they're living or staying. And then sometimes a nurse will answer. In one case, a patient hadn't been seen for 2.5 hours after foot surgery. And so I got in touch with a nurse, and she said, well, I've been sitting here for 20 minutes and nobody's called. And I said, but this patient's been calling you for 2.5 hours. So a lot of times it's just to talk with patients and families to be persistent. Don't give up. There are very caring, wonderful extremely excellent professionals that still reside at Mission Hospital, and you just have to be persistent and not be overwhelmed. And the last thing I'd say, one of the things I do with my patients when I go to the hospital or any other time is point them to mayoclinic.org, which has got a great patient education part of their website, and it helps them understand their meds, their disease processes. On one patient who had a hip replacement, she was very upset because the surgeon hadn't come in and told her what kind of thing happened in her hip. So I asked the nurse to come in to the room, read the progress note, read the op note, and please tell me what kind of appliance that patient had. I quickly looked it up on mayoclinic.org, and the patient was relieved. So I just am honored to be here on this panel. And I would say to everyone, never, never, never give up on your healthcare. And thank you very much for letting me speak these words today.
Thank you very much, Karen. I know you have a variety of other terrible cases with patients, so you've spared some of us the agony of hearing worse cases than the one that you raised. Next, we're going to turn to Senator Julie Mayfield. Julie has had some direct experience in dealing with HCA herself, both in her political role and in some legal issues. So, Julie, over to you.
Great. Thank you very much, Barbara. So happy to be here as a part of this overall event and this particular panel. So what I'm going to talk about, well, let me back up for a second. So you've heard a lot about what happened to our community in Western North Carolina in the wake of the HCA purchase. And many of you who are on the call or in the Zoom might live here and you might have experienced this yourself. So I don't need to go into any of that. But what I'm going to talk about is what we might have in place or get in place in North Carolina that would help prevent a lot of the problems that you have heard about today from happening in the first place. So and I'm going to talk about two different things. The first is a piece of legislation that I have co-sponsored with two of my Republican colleagues here in the Senate. And then the second is focused more on conversations about what could we do about the corporate practice of medicine here in North Carolina. So I'm going to start with the legislation. And I should say that when HCA purchased Mission Hospital, I was on Asheville City Council at that point. So I had a little bit of a front row seat to the degree that there was a front row seat, but that experience influenced a lot about my involvement in additions to this piece of legislation. So what this legislation would do is it would give the North Carolina Attorney General significantly more authority to review these hospital mergers and consolidations than the Attorney General currently has. Right now in North Carolina, the Attorney General has very limited authority in reviewing proposed hospital mergers. Basically, if it's for-profit to for-profit, it's just a competition analysis. If in our situation, it's a for-profit acquiring a nonprofit, there is an additional level of review, but it's mainly just to make sure that those nonprofit assets are put to work for the community for the charitable purposes that they were intended to be used for. So you'll see in there that there's nothing about the Attorney General doesn't get to review these deals for anything around quality of care, accessibility of care, anything like that. And I know a lot of folks in Western North Carolina are very frustrated about this deal, the sale of Mission to HCA, and a lot of people feel like our current Attorney General, Josh Stein, should have done more to stop it. And what I can tell you is that he did not have the authority to stop it under current North Carolina law. And in fact, he pushed the envelope of the authority that he did have really pretty aggressively to secure assurances and agreements from HCA that are binding on them for certain periods of time. So, but what this legislation would do is vastly expand that authority and give the Attorney General the ability to look at the impact of the deal on the following four things. And these four words are together in the statute multiple times. And those four things are cost, availability, accessibility, and perhaps most important, quality of care. And ultimately, if the Attorney General determines that the deal would have a negative impact on any of those four things, cost, availability, accessibility, and quality of care, the Attorney General can take action to stop the transaction. So that's a little bit down the road, but let me back up a little bit. So as part of consideration of these proposals, and let me actually just say the bill would kick in for transactions that are over $5 million. So it wouldn't capture every little transaction, but it would capture the really big ones. The Attorney General would have a pretty significant period of time to review the deal. The Attorney General is authorized to pull in experts from the Department of Health and Human Services to look at what DHHS thinks the impact of the deal might be. And then most importantly, I don't know about most importantly, equally importantly, at least for me, is there's a very robust public engagement part of the transaction at this point. So during the Mission HCA deal, There were no required public meetings. There were no required public hearings. As I mentioned, I was on Asheville City Council. Nobody asked the local governments, the relevant local governments, what we thought about the deal. We did have some meetings with mission officials about the deal to learn more, but we asked specifically for HCA officials to be present in those meetings, and we were never allowed to speak to anyone from HCA. They were never present. So all of the answers that we got to our questions were from mission people who, of course, as soon as the deal was done, were on planes out somewhere else. And what we learned later is that much of what they told us was just a flat out lie. Whether they knew it at the time, I don't really care. I think they did probably. But the point is, in our bill, we have crafted a public engagement structure that would require both the acquiring and the entity to be acquired to be present, to answer questions, to provide information, create a public website where information can be accessible by all, by anyone. Local governments are asked for their opinions about the deal. So just, enormous opportunities for public input on the deals that don't exist now. As part of the review, and if the Attorney General, for instance, decides not to object to the deal, the Attorney General can require the acquiring entity to essentially sign an agreement that says, I'm not objecting to this deal going forward, but here are the things that you're going to do as part of the deal. And those, those things can be varied. They could be, you're not going to reduce staff for the first 6 months or first year. If we had that in place in the HCA mission deal, things would have been so incredibly different. I mean, if they had not been able to let anybody go, as they did, as Mayor Kopelov said, they slashed staff across the board in many areas. If we had been sort of fully staffed by the time COVID rolled around, a year, which was just a year after the deal, our COVID experience might have been, just so many things could have been different. So they could have, in this agreement, there could be agreements about staffing. Could be agreements about closing, when or if facilities could close, the timing of that. When, if they need to build or create new facilities. And some of those things are, of course, as part of the Mission HCA deal. So they built a new hospital in Franklin. They're opening a new mental health facility in Asheville. So that deal did create some obligations, of course, for HCA. This legislation, again, would sort of expand the ability of the Attorney General to require conditions of the purchase effectively. And I want to read for you, if the Attorney General does determine that the deal would negatively impact cost, availability, accessibility, and quality of care, the Attorney General, as I said, can file an injunction to prevent the deal from going forward. And here's kind of the standard, here's the language from the bill, the standard that a court would use. So the Attorney General can file, and the transaction cannot be consummated if there's clear and convincing evidence that the transaction would have significant and deleterious effects on the cost, availability, accessibility, and quality of healthcare in any portion of the state, and that the negative consequences of the transaction outweigh any benefits. And I just think, I wonder how things would be different in our region today if this kind of law had been in place when the Mission HCA deal went through. A couple of other things the bill would do: it would require post-transaction monitoring for at least 3 years, possibly up to 5 years. Importantly, it gives the Attorney General the ability to come in and enforce the agreement if the acquiring entity is violating that agreement in any way. And that is different than the situation we have now, where it's really an independent monitor whose obligation is to monitor the agreement, and it's the job of the Dogwood Health Trust really to enforce the agreement. So this leaves all of that with the Attorney General's office. And I should say, so this is Senate Bill 16. If people want to go look at the bill, there's the original bill that we filed. Some of the things that I have talked about are actually contained in new language that doesn't show up on the legislative website. It's an amendment that has not been run yet because the bill has not been heard. So that's the other thing that I need to say, is that at this point, this bill is not going to pass this session. We're getting very much toward the end of the session. And this is a big deal. This would be a major change in our state for the way that hospital consolidations happen. And they are happening, and they will continue to happen. So my view and the view of the bill sponsors, and there's a companion bill in the House as well, all of us believe that this is only going to become more important. Increasing this level of review is only going to become more important as we have Medicaid expansion here, as more people as more corporations and businesses turn to North Carolina as a place to do business in the healthcare field. So we're anxious to get this in place, but it will have to wait for another day. But none of us are giving up on it. We will continue to advocate for it. So that's the bill. Let me talk briefly about the corporate practice of medicine in North Carolina. And I think, like in a lot of states, folks are casting about for, can't somebody do something about the corporate practice of medicine in North Carolina? And so the Attorney General's office has looked at this, and there's a very old Attorney General's opinion that basically says you can't have the corporate practice of medicine. You can't have corporations owning, medical practices. Physicians have to do that. There are a couple of policy statements from the medical board that hint at that. But I will just say that from my many conversations with the Attorney General's staff, there is nothing that is strong enough to provide the basis for a lawsuit that the Attorney General might bring against, for instance, a Team Health that owns a number of the physician practices here in North Carolina. It's just the legal basis isn't quite there. My recommendation has always been, and the Attorney General agrees with this, that it's really the medical board that needs to be out in front and leading on this. The medical board needs to say to its community, we are not going to put up with this anymore. It is against our ethics. It is against our principles. And we are going to take a stand against it and adopt some stronger policies about it. And at that point, then I think the Attorney General would have a stronger leg, would have a leg, I won't even say stronger leg, would have a leg to stand on in pursuing some of those issues. The other way to do it would be, again, for the legislature to pass a very clear law that says physicians must own physician practices, that corporations are not allowed to own physician practices. I would love to draft that bill. I would love to introduce that bill. I think it would be very, very challenging to get it through. The medical world here is incredibly influential, both for the good and the bad, depending on what the issue is. So that would be a challenge. But it doesn't mean that we shouldn't do it. All of this is going to be hard work, and we need to do whatever we can to, in my opinion, kind of restore our community's confidence in our hospital and in the medical care that's available in Western North Carolina. So I'll stop there.
Thank you, Julie. Thank you, and it's good to know that some of that legislation is coming. So I'd like to just ask if the panel has questions for one another that you would like to discuss now, and then we will open it for conference participants to ask the panel questions. So I'll start with you. Who wants to go first?
I would just like to make a statement, and this follows up with one of your comments, Julie, that in our community, we hear a lot of people blame the Attorney General for allowing this sale to go through. And one of the things I say to my colleagues that it was the board of directors who were the boss of the CEO who allowed this sale to go through. And this action occurred as a result of their agreement. And it's unfortunate that there are non-disclosure agreements for perpetuity's sake, but that's really, I just want to make that comment.
Thank you, Karen.
Sorry, can I just respond to that? Having spoken to a number of those board members, they actually feel the same way a lot of us do. They feel like, well, they don't feel like, they know that they were also lied to about what this deal meant for our community and what it meant for the hospital. And I think if a number of them had to do it over again, they would not do it, or they would do a deal but with somebody else.
So I'm not an attorney. My question is, if they signed a non-disclosure and things were not disclosed to them and they agreed to the sale, why can't that be pursued?
So it's at that point, it kind of becomes a private transaction. It becomes if I sell you a car and it doesn't work, and then you can come back and sue me for the car, but the Attorney General can't come back in and sue me for that car not working. So it's again, it's possible perhaps that there could be some sort of private right of action by board members. They would essentially, I think, have to sue themselves, which would be a very difficult thing to do. And I don't know that there's unanimity among that group, or even a majority that think that this was not the right decision, or that they felt like they were misled. But we also don't know what questions were being asked. For instance, did anybody ask, are you going to come in and slash the staff? I don't know. I would hope that they asked that question. Did anybody ask, are you going to come in and slash the contracts with physicians, essentially putting them in untenable positions of leaving or taking extraordinary pay cuts? I don't know that anyone asked. So I think some of these decisions are decisions that HCA made after the acquisition. I feel absolutely 100% confident that they knew exactly what they were going to do to save money before they made the purchase, and they didn't share it. They didn't share it with Mission, or they shared it with Mission and Mission didn't share it with everybody else. But I think that's why it's absolutely critical in these deals going forward that the acquiring entity is required to be present and answer questions of, frankly, anyone who wants to ask them.
Well, Julie, I'd like to sort of put the question on the table for everyone as to what do you believe is the potential for change of the current situation?
I'll just go first. I'm sure everybody has their own thoughts, but so I think about this situation more than I think about any other single problem in our community, and that has been true since early 2020. There is nothing more important in our community than this. And I have come at it from several different ways in terms of what I think the right outcome is. A lot of people have said, well, we just need HCA to go away. Well, I'm here to tell you HCA ain't going away. I don't think we can undo that deal. I don't think they are going away. They make a lot of money on this hospital system. And, so then I sort of pivot to, well, could we change the culture? And, sadly, I think the answer to that is also no. As Maureen has found and others have found, the culture of this organization is established not in this city. It is established in Nashville. And they run their hospitals very much the same all across the country. And as I have heard someone who worked both at Mission and for HCA describe their culture, and they are risk averse. They really don't care about public opinion that much. They're not going to do anything that sets precedent. And there were, a few other things, and that, so, that has also sort of defeated my thinking about changing the culture. And so I don't have an answer to how we change it. I think all of these are efforts. I continue to try to put in front of HCA and Mission Hospital opportunities, as I say, for them to say yes to things that would be beneficial for our community, that might make people feel better about them. And I will just tell you that every single one of those has been met with a no. And that is extraordinarily frustrating to me. So I don't have an answer.
I would add, I think, I agree with Julie that they're not going to change. I've talked to Sam Hazen personally several times, asked direct questions, asked him directly to change how those contracts were done with doctors. And, it was an absolute no. The only way they're going to change is being forced to by a court decision. So that anti-competitive, that, non-transparency, that bundling, all of the things that they are doing that contributes to a big part of the problem. It's going to have to be directed by a court decision. And that's one of the reasons why we are forcing our lawsuit to go forward. That they are a monopoly here, not just a monopoly. Well, I love it when HCA says, well, monopolies aren't illegal. Well, they're right. They're not illegal, but they are a predatory monopoly that are using anti-competitive practices, or so we allege, as my lawyers tell me to say, so we allege in our court case. I think we have got to continue with citizens, with entities, with municipalities, with counties, we need to hold them accountable in the court system, and we need to make it hurt financially with decisions, because that's the only attention that we're going to get is when we hit their bottom line.
Just a couple comments from my perspective. I think certainly the legal pressure that is put on them hopefully has the potential to have some impact. I'm not terribly optimistic because they are so massive, and their ability to fund a counteroffensive on the legal front is strikingly high. That said, I do think, and some of this is perhaps self-preservation, but I think if you take a long-term view, there are some growing movements that are not necessarily unique to Western North Carolina, but are happening nationally. And this conference is a nice example of that are going to try and shift the tides, if you will, related to this. So, one example would be simply, physicians leaving the system and doing things more independently. Another example is employers starting to pay for healthcare differently. Employers are the largest payer of healthcare in our country by far. 150 million Americans get their health benefits through their employer. They are the largest payer. They have power in that. And as they increasingly push back against the status quo system, they will start to get the attention of the folks that are delivering the care. The entity that was created from the sale of HCA, if it does a good job at what it is set out to do from a social determinants of health perspective and takes a 25+ year view, has the opportunity to really start changing some of the social determinants that influence the need for people to access the types of care that HCA really leverages and all hospital systems leverage in order to make money, which tends to be when people are really sick and need high-level procedures. And so there is an opportunity there, but it takes a very long-range view, because those things, even if you do a good job changing them today, really take 5 to 10 years to manifest from a wellness perspective. Maureen and her community are leaders in our region with this type of work, with their Blue Zones project that they implemented as an example of something that is already having an impact now 2 to 3 years in, but could have an increasingly tremendous impact from a 15 to 20 year plus view. And then at a federal level, really some of the pressures that are starting to be put on healthcare systems from a transparency perspective, from the Consolidated Appropriations Act, the No Surprises Act, where hopefully we are going to start to kind of make this really highly unregulated and untransparent system start to talk about things like how much does something cost, and share that in a transparent fashion to get away from this game of no one really knowing it, and lots of middle players extracting immense amounts of value from our community and from our economy because they can, and nobody knows that they're necessarily doing it. So I think some of this, again, perhaps is self-preservation, but I do think that these types of movements are going to take time, and they need to be multifaceted. And a lot of the people that are listening in on this type of a conference, if we can come together to try to drive that change and take a longer term view, I think that there will be a possibility. The final thing I'll mention is the certificate of need laws. And so I think Julie is probably much more an expert on this than not, but as it relates to someone coming into our community to do the same thing that the big behemoth is doing, and increasing opportunities for that, I think we're going to see it at a procedural kind of surgical independent surgery center level, at a radiology level, and then also at a hospital level with the likely addition of a new hospital player in our community in the coming 2 to 3 years. It will take time, obviously, for that hospital system to get to the size and or the potential to be a true competitor, but it is absolutely a place to start.
Thank you, Ben.
I would-
Sorry, go ahead.
I would just add that one of the things I always tell my patients is to please call the North Carolina Division of Health Service Regulation Complaint and Investigation Section. It's a 1-800 number, open 9 to 12, 1 to 4, and that's just to lodge all these complaints with state agencies so that possibly they can be aggregated or looked at or something, instead of these complaints just going to me or just someone else without any follow-up. So that's just another strategy.
Yeah, and I'll put it in the chat, but I do the same thing, Karen. Everyone, and I get a lot of emails that are complaining about care admission, and what I send back to them, make a complaint with DHHS, and you can do it online, by phone, by email. There's several ways, and I'll just put that in the chat.
Thank
and
you.
everybody, please feel free to share it. But at some point, I mean, once a hospital is accredited, it can be very difficult to undo it and bring down sort of serious enforcement action due to patient care, but it's not impossible.
Okay, we've got a little bit of time left here, so I'd like to invite those who have been listening to the panel to put your questions in the chat, if you can, so that I might be able to present them to the panel. If I look here at the chat, we'll see if there are questions pending. I don't see any right now.
Barbara, let me just tag on to kind of what Ben was speaking about. So yeah, employers need to understand how to get out of the traditional system. They need to understand about how insurance works and the potential of being overinsured and having insurance built where it works for your employees, because not everyone can have a one-size-fits-all insurance plan, especially if somebody's on specialized pharmaceutical drugs. They need to be able to have access to that at a reasonable cost. So it is working within our community with pharmacy, such as like we had worked with Sona Pharmacy. They've been great on negotiating prices and being very transparent. So, in the membership plans, if we can keep people healthy, if we could institute what Mitch has talked about, which is a kind of like some sort of a membership-driven ER center, the more that we can keep people out of the hospital, keep them healthy, it's going to benefit us all on so many levels.
Thanks, Liz, for that observation. I'm not seeing any questions coming up in the chat, so I'd like to sort of insert something here myself, so we have a final round. One of two people on this panel are involved in the antitrust suits, the two antitrust suits against HCA. Julie, as our lawyer here on the panel, what are the potential consequences of having those antitrust suits be judged against HCA?
Well, I am the lawyer, but I'm not sure. Because I'm not involved in either one of those. I'm not sure. I don't know if Mayor Kopoloff or Liz could talk about sort of what the remedy that they're seeking is in either of those cases.
Maureen, do you have an idea of what?
Yeah, I can talk about our case. Our case is somewhat specific. It's it's a class action case, but it's for self-insured entities. Not just municipalities, but we've been joined by others. But and we're asking really for the remedy we are asking for is for them to stop specific practices, and that is the tying of the hospital services to all of the outpatient services. It doesn't do any good to have additional options, medical options, if when I do the insurance for all of my employees, the only only outpatient practitioners they can go to are HCA practitioners. So creating and doing away with that bundling, making that illegal, because that really prohibits competition. When you have HCA, and they have approximately 80% of the market here, and they dictate that the major insurers have to have the outpatient services with them if you want to use Mission Hospital, which is the only regional, I think, a tertiary level hospital in the region. So you have to be able to have that hospital in your insurance plan. So you're so forth. So one of the remedies we're saying is that they have to stop these practices. They have to stop that, which would allow competition to grow. Allowing competition would allow pricing to become down to competitive levels. We are now at supra competitive pricing with HCA. We would and the transparency, which Ben had talked about. That's another remedy. One of the things that we specify in our lawsuit is that they deliberately do not provide transparency. So as an insurer, the city here, we can't even look at and compare prices between different healthcare options because they obscure that transparency. So having those anti-competitive provisions prohibited here, I think would go a long way to opening up other healthcare options and allowing entities like a small municipality to actually look at what are other options that might be out there that I could use for my employees. We talk about employers need to understand, but employers have to have options that are realistic for putting your entire workforce under. So that was one of the remedies that I think that we have specifically asked for in that. And then the other remedy is that they reduce their pricing down to normal competitive levels, and that they pay the overage as well as any damages to all people as part of the lawsuit. So I think there are some larger ramifications than just the fact that maybe the city of Brevard will get some money out of this lawsuit, but the bigger ramifications are that we're going to change the way that they control the market here. And once they lose control of that market, that will open up, I think, a lot of other options. And I think that's the big benefit to this antitrust lawsuits. And I'm very optimistic that we're going to have a favorable outcome on this.
Thank you, Maureen, for that last optimistic note. Much of what we've been discussing has been somewhat bleak, although Liz and Ben presented some options that are sort of alternatives for people seeking decent health care. Thank you, Julie, for bringing us up to date on what the potential is on new legislation that could address the issues around hospital consolidation. Karen, thank you for the patient information. I really appreciate you all participating in this panel today. I do think that this set of issues exemplifies the issues that Mitch and his colleagues in the Take Back Medicine realm, we are a microcosm of having the need for taking back medicine here in Western North Carolina. So I thank you for all the details that you presented on this. So I will turn it over to, we do have actually one question here in our chat, which is, what are the thoughts on doctors unionizing? Would that make a difference? Ben, you might be in a position to say something there.
Yeah, I think possibly yes. I don't have a lot of expertise in that regard, and certainly I think listening in on some of the conversations related to this event and some of those from yesterday, there are certainly physicians who are considering this and potentially pursuing this in certain regions where there is a possibility. I think anything's worth exploring, but I don't have much expertise or thoughts beyond that.
Yeah, well, I do think at a minimum, some of the issues that were raised earlier today in the conference around due process rights and issues against retaliation to physicians. I know from personal experience that when I have tried to report on some of the issues affecting doctors here in Western North Carolina, the issue of retaliation is very, very high on their radar and feel very constrained about saying anything in public. So despite the fact that it's clear that there's a lot of physicians who are extremely uncomfortable and but have yet to be able to say something publicly. So at some point, perhaps we will have a doctor union, but I don't know how soon we'll be able to see that and how much they would be able to push back against entities like HCA. So let's see. I don't think I have anything else in the chat, I'm sorry to say. And we do have just a few minutes left. If anyone wants a last word. Oh, wait a minute. What is next in Western North Carolina for Take Back Medicine? I think we've covered that a little bit. Anyone want to respond to that particular question? What's next for Taking Back Medicine in Western North Carolina?
I'm happy to take a stab, if helpful. I think events like this and actually cross-connecting across disciplines is a step in the right direction. So to have representation from advocates and the legal side of things and the civic and more political side of things, as well as the business community and then physician provider communities as well. So I think if we can all work together and continue to have an open conversation and support each other's efforts, then that could be really helpful. Exactly what that looks like, I think, is a lot of grassroots work. To be honest, I think that's where I see it going. And then leveraging those that have strings that they can pull, if you will, or levers that they can push to try to create the change at more of a regulatory level. So I think, Julie, we're going to be calling you probably every day for the next several years.
Let's do it.
Anyone else want to weigh in on that one?
Yeah, Ben nailed it. That's exactly what we need to do is get a bunch of us. We need to get together and we need to dig in deep.
Thank you, Liz. I can't tell you how many times, every time we have published a story on HCA admission, I get emails asking, can we get a movement together against this? So I think there's certainly sentiment out there in the public for some kind of collaborative effort across the community.